Welcome to TARTLEcast with your hosts Alexander McKegg and Jason Rigby, where humanity steps into the future and source data defines the path.
Hello and welcome back to another episode of TARTLEcast. You're here with Alex, your host, and I have a special guest today, Chris Cassel. Now, Chris,
Cassel.
Chris Cassel. I apologize. Everybody forgive me for that public. Would you mind telling our listeners a little bit about yourself before we dive into our topic today, so they know a little bit about your background and who you are?
Sure, Alex. First of all, I'm delighted to be here. I'm a physician, and I've spent my career working in the fields related to bioethics, the moral dimensions of medicine. That's the first focus. Secondly, the aging of the population and the ways that medicine and healthcare more broadly has impact and can improve the lives of all of us as we get older. And the third is in the area of quality of care, measurement of quality of care, quality improvement science, and how technology can help advance that.
Well, and that's huge because, as you and I both know, the possibility probability is like when you age, you're typically going to find some sort of health ailment or dis-ease with whatever's going on, right? And so that focus is figuring out how to care for life and understand that data and the health of an individual, especially as they are aging, is like, how do we continue the continuity of life? How do we make it that much easier, right? And that much healthier?
Right. And if you just even look at the data about the changes in the last century or the last actually 50 years in our country and what lies ahead, people are living longer and longer. There's subsets of people that have actually in the last couple of years where you've seen the longevity reduced because of some of the problems with opioids and other kinds of
those epidemics
challenges. But still overall, and this year again, we've seen increases in life expectancy. What that means on a population level is that our whole system has to think differently about how we deliver care and also how we create the conditions for people to stay healthy, stay active, and for society to take advantage of older people as the population ages. That's the population side of it.
Sure.
The personal health side of it is that every person is aging at their own rate and their own individual medical challenges. And there are people, and sooner or later, probably most of us, who will face really life-altering functional decline of some sort. And you have to have a healthcare system that knows enough of the science of aging that you can intervene on the things that really make a difference, keep the patient safe from the risks of healthcare, like hospitals are really high-risk people.
They're made to make you healthy, but you know.
Yeah, but if you're 95 years old, you should try whatever possible, because you get infections, you can fall, you're exposed to all kinds of...
like broken hips, right?
Yeah.
Most of the time they're like, we shouldn't really even put you in for surgery because the risk of something happening after the fact is that much greater.
But, even you're saying that you've seen one 85-year-old, you've seen one 85-year-old. There are 85-year-olds who can flourish after major joint replacement.
You're right.
And there are people who will say to you, the patient themselves know this, and what they need from the healthcare provider is somebody who can listen and who can say, you're right, and not go home, we never want to see you again, and abandon them. But no, here's ways that we can help you live life to its fullest with whatever the disability is that you have.
No, and you're right about that. And, shame on me for saying that just because one person may have the issue of a broken hip leading to an infection, it doesn't account for the other populace of people that go unspoken for.
Right.
And so what we have is this natural bias that comes into play where we're going to focus on only what we've heard and the worst things that can typically happen, within that population, that small subset. But the greater majority tends to flourish. The thing is, without that data in a healthcare system, right, without that insight directly from the person, and then using that to even administer whatever sort of recommendation from a doctor, right, you can't have that unless we speak to that person that is in there, right?
That's right.
And whether it be that one time they come to the hospital or increasing the care of the patients and the longevity of the patients by being in touch with them more often.
Yeah.
So finding a means to do that. But if we consider, you had shared a really nice article with me from the New England Journal of Medicine. Mm-hmm. And it had a focus on data, right? And specifically the data is artificial intelligence. Mm-hmm. So using that machine learning, these fabricated neural networks to go in and use what inputs they have from people.
Right.
And then from that to drive some sort of analysis or understanding for low-income or middle-income countries. Now, we can have a parallel now between the group of 85-year-olds and the low-income, middle-income countries, right? So if one individual, there's a large amount of data that gets used over and over again, saying that if you break your hip, you have a higher possibility of infection after surgery. Mm-hmm. If a lot of people think that, that becomes the norm and the truth, right? Mm-hmm. Because that seems to be the input that gets highlighted all the time. Now, if we're looking at artificial intelligence and feeding those inputs into a system to drive decisions, we can't just have that bias in place. We have to have all the information from all of the people.
Well, and that's a good example where...
Well, thanks, Chris. I mean,
in the first place, what AI can do is if it has the right data inputs,
correct,
big if, and we can get back to that, then it can give better information to the doctors, nurses, public health workers, community health workers, that these are the things to look out for. This person is high risk for falling and breaking their hip.
Correct.
In the first place. Not everybody on the street who looks like an old person, but these three people.
Yeah.
And then, or people with these characteristics.
Sure.
It's predictive analytics.
That's exactly right.
And right now, we have some of that modeling, but we don't have it for all the different kinds of things that happen in the healthcare system and in hospitals where we really could intervene early and prevent people from getting those complications, getting
sure,
that infection. And so then you would have a win-win.
Right. And then that's what we've seen is what happens is the people that typically can support that data, the ones that create it, sit in a higher demographic. So to get information from the middle and lower demographics that typically don't feed it into the system, especially
right,
in poorer countries, right,
yeah,
or more developing
yeah,
countries, there needs to be some sort of means where we can communicate with the individual to then use that information so that it gives us a broader base of info to pull from to actually get a more well-rounded predictive analytic on what may happen.
Well, and you've already gone one step further than even we mostly do it in the United States of America,
yeah,
which is that at this point, most of the good work that's gone on around AI and healthcare uses existing clinical databases from
correct,
EHRs without asking the patient, without even telling the patient that
so
you're doing it. So how do you really
know what's going on? Yeah.
And you know, with all good intentions, because there are no laws regulating this.
No.
As long as the data is de-identified, the governing privacy rule, HIPAA, doesn't apply.
Correct.
And so people are just doing it, but more and more as it gets in the news and you hear about these concerns about particularly the big commercial companies getting
yes,
involved in this because they have a business model which is all about selling their data.
It's all for profit
for them. For other purposes, where the healthcare organization just wants to get the answers.
Right.
The byproduct of that data, of course, goes into somebody else's for-profit company. So no wonder people are getting upset. And healthcare data has even more, people are more nervous about healthcare data than they'll give all their data to Google and Amazon
sure,
and everybody, and they don't really, they may think it's obnoxious, but they like the convenience of what's offered.
It's convenience.
But when it gets to healthcare, there's a lot more sensitivity to it. So there's a whole bunch of people like myself now starting to try to think creatively about how do you develop an ethical and policy model
sure,
that can respect the individual whose data you're using, and at the same time not put a barrier in the way to be able to get all the advantages of using this.
That's correct. And so I think your model that you speak of needs to be tied in to how a business is designed, right? So instead of having this community of just black box assessment of AI, where it says just because we anonymized it, we can still make a data profit out of it, but no one really knows what we're doing.
Yeah.
I think that doesn't bode well in terms of ethics and trust, right? In the morals and the actual sensitivity of what it means of using someone's healthcare information.
Right.
Because it's not me telling you most of the time, like, how I feel in my deepest thoughts, but these are things that are internally going on with me, right?
Yeah.
In that conversation, it's not like you walk in a room, it's like you and 30 doctors, it's you and the doctor.
Yeah.
It's a personal thing that's happening. So we have to make sure that that interaction that happens maintains that all the way as the data moves to the hands of the individual, and we afford them the choice, the opportunity, and the education to know exactly what's going on with that information, where it's headed, and how it will be used, right?
Right.
And so where does that lead us?
Well, there's an additional issue which, TARTLE addresses, which is the question of the value of the data.
Correct.
And that's something that when I first started thinking about this, I thought was highly theoretical, which is that let's just say you want to get involved with some of these big commercial firms that are using, because there's huge money to be made if they get good data. And that's another thing, is getting a big enough representative sample of the right kind of people with the right kind of data. And right now, there's all this information and articles coming out about the bias that's inherent in our current model. So that's a really important part of expanding it. But the second thing is, it's not a bad thing if people make money from creating some of these products, but if they do, shouldn't the person who provided the data have some benefit financially from that as well? And, when I first started writing about that, as I said, I thought it was a theoretical proposition that from a moral perspective, that seemed to me to be
just
a
made the most
exchange.
sense to everybody. That's how life should work.
And everybody said, that's a nice idea, Chris.
Yeah, Chris, good for you. Right.
But of course, it could never work. Right. And so then, I discovered what you're doing.
Yeah.
And I think it has a lot of promise to totally change that dynamic in at least two ways. I mean, you know a lot more, but the two ways are, one, to create more of an equivalence in terms of the value exchange.
Sure.
And by doing that, to be able to get more of the kind of data that's going to make AI work better.
That's correct. Because you and I spoke about this, right? If someone has some sort of medical condition, and if I walk around publicly, I'm not going to share that information, right? It would take a lot, or at least some time between an interaction between me and Chris, that we know each other well enough that I'm comfortable enough to share it.
Yeah.
There's this point of incentive and comfort. So with TARTLE, getting access to information that otherwise isn't available and directly from the information, the people that are creating it in their health record, you now have a bridge through the incentive of paying them for that information, right? That they've essentially created over the long period of their life, through the labor of choices they've made. That's something they own. Right. But that bridge, that incentive, allows you to get those things that are just a little bit more private. And if they really want to know the nooks and crannies of me or you, you're going to have to pay a little bit more, And that's going to come not to TARTLE, but that pay goes directly towards the individual. So it creates that financial inclusion, right? And it also gives them deeper, richer data sets that they otherwise didn't have their hands on. So their AI models can now flourish, right? There's just a lot more good that can be done with it. Your epidemiology studies will start to make more sense because you have a real, true population.
Yeah.
And lucky for us, because we're in the United States, everybody has cell phones, smartphones. And if you go to low-income and middle-income countries, they all have smartphones too.
Right.
So affording that access and that opportunity on a global marketplace that TARTLE is delivering, we can speak to those models of morals and ethics and data and that inclusivity and that equivalence that you speak of.
And that's part of this New England Journal, or the recent one that you mentioned, that really is focused more on the international scope.
Correct.
And these more resource-challenged countries where the value to the individual would be greater. And
Sure.
in one case, there's an ethical issue there too. You want to make sure you're not exploiting people's poverty, that they're selling their data. But because the encryption is so powerful,
Yes.
it's not I think that's not a risk. And also, it I think can give the local officials or public health people in that country tremendous tools that they don't now have. They don't have a lot of resources, how to prioritize where they put their resources and
Correct.
who really needs help and what they could do to help their populations, be more healthy.
You can really focus on them at that point. And
Yeah.
you spoke about, not, abusing people like financially, right? And the beauty of this is, just because they're in a different area doesn't mean their information is going to be worth less. The design of our system will show you everybody what the market value for that data is.
Yeah.
So I'm not going to choose a developing country and say I'm going to take 60% off of what I was bidding for U.S. healthcare brackets. That's not fair.
I see.
Everybody through the transparency gets to see what the market value for that information is. So when they say, okay, do I want to fill it out and sell this? Yeah, I do, because now I know what the value of it is.
Yeah.
And you're going to know if someone's trying to game the system if they put in a low bid.
Well, and that's the other interesting part, is that there was always this question about if you were going to provide some kind of financial reward to the data providers.
Sure.
What would it be?
Yeah,
and what you've done is create a marketplace to answer that question.
Correct. And that way it gives it that free market flow, and both parties can decide on that value, where we can meet each other in the center and be like, you want to know something? Me as a buyer and me as a seller of that information, I know what the value is to me. What do you think the value is? Will that work? No. Okay, then I'll wait for a better price. Wait a minute. That price works. I'm willing to give it up for that.
Yeah.
And that's what we've created. And I think this is all in the end going to lead to a more positive outcome, even on a global level, for the care of patients and people that don't have any care, and these just laying a roadmap and a foundation to bring everybody up to the level that we're currently here at in the United States, right? Because it's just a matter of information and getting access to it that'll help us make those decisions to get there.
A lot of that is true. And, there may be other ramifications of this that we haven't, even imagined, in terms of how I'm a big believer in data transparency. And so if we come to see how, let's say, other countries might be it gets back to the question of aging. Even though we live a long time, and as the baby boomers age, people are going to be the fastest growing group of people in the United States is the people over 85 right now.
Correct, yeah.
But we're not the longest lived people in the world. We're like number 20, 30, 25, 26, I think, in terms of other countries in the world who live longer. Some of them are wealthy countries like Japan and the Scandinavian countries. And some of them are not. And so what's the secret? How do we understand? Maybe we're always struggling with the cost of healthcare in this country and how much we spend. Maybe there's ways that people can live longer, healthier lives
with
that actually don't
cost that
much money. What would those be, and how can we find out?
Well, now it's possible to find out because you can go directly to those people, ask them how they live their lives, the choices they make, the food they intake, the sustenance, all of those things that.
So it isn't like they can only take the data packets out of their electronic health record if they should happen to have one.
Right.
They can. This is actually primary source data.
That's the beauty of it, Chris. That's why it's source data. Right?
Yeah.
It's not the secondary or the tertiary information. This is primary. That's like getting on an emotional level with the entire globe, like what you and I are doing right now.
Yeah.
It's being able to have essentially that dialogue and create financial opportunity at the same time.
Well, this is happening just at a moment when it's really important to get the word out. I'm glad we're having this conversation.
Chris,
because
so am I.
These articles in the medical literature and everything you're seeing in the popular press is headed towards regulations, saying there have to be government regulations. The European Union has issued the first swath, and we're expecting more of their regulations. The World Health Organization has a whole working group on this. But there are really smart people, and they sort of realize we're not sure how to regulate this kind of thing because it's so huge, and it's not susceptible to the normal kinds of transactional regulation that other kinds of healthcare really is. So it's really important that these kinds of opportunities be available while policymakers are thinking about, so that they're not making yesterday's regulations for what should be tomorrow's technology.
Chris, that's a really sharp comment, because we can essentially look at the design of TARTLE and then put that into, is this the proper policy design we should be looking at that has that proper ethical, moral, and financial, implementation for the public? And I think hopefully we become that, leading model for people to actually follow, to say that, wow, you want to know something? We didn't think this was possible, like they were telling you before when you were originally writing your papers.
Right.
I guess it is possible. And maybe this is something we should look to, and everybody should look to creating their businesses or this inclusivity or whatever it might be that will bring the world to, frankly, just a better place than it was yesterday.
Great.
Yeah. Well, Chris, I appreciate you giving me this time. This has been really nice. It's been insightful, and I know all of the viewers are really going to enjoy this.
You're welcome. Yeah, this has been a fun conversation.
Thanks, Chris.
Yeah.
Thank you for listening to TartleCast with your hosts Alexander McKegg and Jason Rigby, where humanity steps into the future and source data defines the path. What's your data worth?